Today, we're going to be doing an Instagram Live with a new guest to this page, Dr. Kristi Disapri, who is an expert in osteoporosis. We're going to be talking all things bone health, answering so many of your questions, and I am super excited to bring her on. She is one of the world's leading to be discussing what you can do if you've been diagnosed with osteoporosis and how to prevent it. I think so many of my patients are.
Okay.
Yes. Hi, how
Hi
are you?
there. So sorry. Oh, always.
Oh no, it's okay. We are good. We are good,
Yeah.
good to go. So welcome, welcome. My followers are on fire.
I,
We had so many questions coming
oh
in.
my
So first of all, introduce yourself. Tell us a
God.
little bit about your background and how you ended up specializing in this.
You bet. Well, thank you, Dr. Mary Claire Haver. So exciting. Everyone in my office and my patients were so excited. I got so many texts and family and friends who didn't know I did menopause, but they knew you. Even my sister-in-law, who's hairdresser, was like, oh my God, that's amazing. So I am so happy to talk bone health. As you see, I'm really excited. Finished seeing patients for a full day here in Chicago. So fun. I have a DEXA here in my office. So we do this day in, day out. That's why I love, doing this. Thank you for your, attention, your awareness in the menopause space, making it fun and cool because we are women. We are a huge mass of postmenopausal women, and we need to take care of all the things from, I always say, from our brains to our toes. And our bones are in the inside, and we don't feel those, but we do know that they change at the menopause. So with all that, I'm a board certified internist. I actually started in OBGYN. I like delivering babies, but I liked what happened afterwards better. So I really focused more on like the midlife women's health. I did a fellowship at the Cleveland Clinic. So I've practiced sort of a hybrid of internal medicine and gynecology for the past 15 years. I was an assistant professor at Northwestern and working with some of the people that you already know, like Dr. Lauren Stryker, and in the menopause clinic, and really running the osteoporosis program there. And then I sort of took that show on the road and have opened my own practice, Bone and Body Women's Health, in the northern suburbs of Chicago. And I see women here, and then also, people come to see me from all over. I was so honored. I had a patient last week who flew from Alaska to see me to get a DEXA and repeat it and talk about her severe osteoporosis and have the couple hours time to do that. So I was so honored to meet her. And so we'll see patients from the surrounding states, really focus on menopause. I'm a menopause certified practitioner, just like you, do a lot in the research space, do a lot in the teaching space, and just think this is an area as many of them, like sexual health and GSM and brain and cognition, is one of the areas that we sometimes forget about when we talk about menopause. So
So tell us what osteoporosis is. I think people have a rough idea, but just kind of break it down from, what is it? How do we define it? And what does it really mean?
yeah. So I think, the word osteoporosis doesn't really help itself. It doesn't tell us, if we know erectile dysfunction means that there's a condition. Osteoporosis, unless you speak Greek, you don't really know what that means, right? Osteo means bone, porous means thin. So osteoporosis is really just a condition of our bones weakening, thinning of the cortices of the trabecular, which is the inside part of our bone, which makes it strong, and the outside part that makes it strong. And that predisposes us to have osteoporosis related fracture. So osteoporosis can be defined many ways. So the condition, a lot of women don't know they have osteoporosis unless they've had a fracture. That's one way to define osteoporosis. If you had a fall from a standing height or less, or a twist, a turn, a bend, things like that. Or if you have we'll talk about this, a screening bone mineral density that says that bones are fragile or thin or below what we would expect for someone who is of peak bone mass. And so really, again, it's an intangible condition. I think that's what makes it really hard to both evaluate, sometimes treat, because I see so many women like you do who say, I feel strong. I've had calcium my whole life, especially remember I'm in the Midwest. So we love our cheese and our yogurt. And so they're like, where have I fallen down with this? And it's like, well, again, there's no warning signs for osteoporosis. There's no hot flash that says you have low bone density. And so we really need to be sort of more sleuths about, and more advocates really for ourselves about thinking about bones before, during, and as I mentioned in the post, after, the menopause transition.
And talk about how menopause affects or impacts our bone density.
Yeah. So I think that's, unless you just, crawled out from under a rock, we all know that menopause is like hit center stage, right? We are in this time where there's been, a menopause sort of, minute, and now it's a movement, and it's so exciting. But what is exciting, I think, for the scientists like you and I and the physicians like you and I is, you've been in OBGYN, I've been in women's health for a long time too, is we've known this. This is not new to us. This is not new information. It's new because we are finally talking about what happens in the post-reproductive years for women. But we know that, menopause, whatever that is, whether it's surgical menopause at 40, I have many women in my practice who have genetic breast and ovarian cancer, and they have, elected to have hysterectomies and bilateral septal oophorectomies, or if they have natural menopause or early menopause, we know that is a huge factor for so many things, not just our bones, but our symptoms, our risk of dementia, our risk of cardiovascular disease, our risk, again, of bone density. So what happens at menopause, primarily, again, if you have ovaries, you will go through menopause, is we have a steep drop in estradiol, or estrogen, secreted from our ovaries, and other hormones too. And estrogen is exquisitely sensitive on a lot of tissues. Why do we think we have hot flashes? Well, it changes our hypothalamus. Why do we think we have genitourinary syndrome of menopause? Because we have changes in our vagina and vulva. Again, we don't feel the bones, but we know these crazy statistics that women can lose up to 20% of their bone mass. On average, it's closer to like 7 to 10%. And we know that from really good observational studies looking across women across the menopause transition, which is called the SWAN study, and the Women's Health Initiative study, which hopefully will stay with us with all of our advocacy. So we know that this happens, and it happens not just a light switch, is what I tell patients every week. It happens over time. So even in the perimenopause, we know we start to lose bone density. And so it's why it's very important when people say, well, what can I do at menopause to prevent my bone loss? Well, actually, it starts earlier than that. We know menopause is, important, but we know that the bones that we bring to menopause, just like our other symptoms or health conditions we bring to menopause, are important. And then the amount of time and our symptoms at the time of menopause and what our bone strength is there. And then afterwards will also, impact our bone strength, bone density, and our propensity to have a fracture. So again, it's that estrogen during that transition, our peak bone mass before we get there. There's a lot of discussion about that now, especially since we have so many great collegiate athletes. We have women who are in sport more. I see a lot of those patients in my practice. I see all the Northwestern athletes here in my practice. And so, right. And so people come to menopause with vitamin D deficiency or early menopause or genetics, right? Let's not underscore the importance of genetics, low bone density. I say to patients, why do we ask if your mom had osteoporosis? The patient I just saw left here, her mom had a hip fracture in her 80s. She's 61. That's incredibly important information for us to understand, because that's a genetic predisposition to have a fracture herself and have low bone density herself. So we need to know our history. We need to know our medications. We need to know what our reproductive histories look like, our family history.
I'm seeing patients who are wondering, is it genetics? Okay, so we have our genetics. We know, based on your mother's history, your father's history, even, if he had an osteoporotic fracture. That's my very best friend right now. His father had a hip fracture at 85 from a fall from a stand and was diagnosed with osteoporosis. She went and immediately got screened at 56 and has osteoporosis. So don't forget the dad, because men have
And
osteoporosis too.
sisters. I love it. Most people know more about their sisters than they do maybe their sisters and their pets. I always find we all know about our pets' history, but it's so true, because I think we're finally, we do much more genetics on for genetics for breast cancer and cancers now, but we need to ask about these things. And so, and you mentioned your, the 85-year-old with a hip fracture. Remember, we all, as we want to think about it or not, we all age. So when I look at women across the decades, my youngest patient in my practice is 37. My oldest patient in my practice is 96, right? So we have to think about this in decades. And I think that's where we're finally moving the women's health needle, right? So what happens between 40 and 60? Well, 95% of women will go through the menopause transition, or even 45 to 50. What happens in the postmenopausal years? We know specifically when we focus on bone today, we know that the bone density and the bone loss is slow, that we can lose 0.5 to 1% a year, but that continues, right? And let's not, underscore the importance of muscle loss. That there's muscle loss every decade of life. And if you ask 70, 80-year-old women, they'll tell you that. They'll say, yeah, of course I feel like my muscles are different or they can't feel their bones. But we know that we see that. So again, there's this dramatic loss at menopause. And for some women, that might continue. For some women, they're not getting their first DEXA until 65, which,
So let's talk about that. That is the number one question. I personally do not follow the guideline at all. Everyone I can get into a DEXA machine will have an bone density scan. I feel like at 65 for so many patients, we could have intervened. You know, when they see those numbers, they get very motivated to start doing lifestyle interventions and looking at therapy. How do you, let me let you, you're the expert. So,
yeah. Oh, and actually, that we have seen, with all of our guidelines, the guideline soup, whether it's endocrinologists or rheumatologists or internal medicine, a lot of us follow the United States Preventative Services Task Force, and sometimes that's what the insurance wants to follow as well. And thankfully, we did have some positive, movement this year. In January, they recommended that, yes, 65 is like, sort of like everyone should have a DEXA by then. For 70 for men, way too late. Again, we know that 1 in 2 women over the age of 50 will have an osteoporosis related fracture. The NHANES or the IOF looks at all the epidemiology and prevalence. We know that maybe close to 10 to even 20% of women will have a low bone density right from the start or osteoporosis. So that's a
mhm,
huge, and worldwide, when you think of 10 to 20% right off
mhm.
the low bone density. So the recommendation from the United States Preventive Services Task Force is that if women are going through the menopause transition, remember that's the time, the years before and the years right after, and they have one risk factor for bone loss. So that could be you've lost some height, you already had a stress fracture, you have vitamin D deficiency, you have a family history of osteoporosis, you have a condition like celiac disease or rheumatoid arthritis. Woman I just saw had rheumatoid. So any sort of one little push us over the edge, we should be getting a screening bone mineral density. 2025, we can get breast imaging for mammogram, MRI, we're doing risk assessment there. So, we're trying, right, to do that a little bit better. We can do this better as well. And that's why my DEXA car is what I call it. My car in my office would just be DEXA, and every woman who walks through my office, unless they don't want a DEXA or have had 3 in a year or something, we do a screening bone mineral density. If they have good normal bones, we know that at menopause, we should repeat that in a couple years because things change. If they have a low bone density at baseline, we know we need to intervene more quickly. And we'll talk about treatment, I imagine, here in a second.
Um, let's talk about
Mhm.
prevention. So a lot of my patients or followers really come in really motivated. And I think there's a lot of misunderstanding, misinformation. When we talk about lifestyle interventions, nutrition, movement, exercise, I've looked at the studies on weighted vest. They were done in frail patients in nursing homes. They saw improvement. My line of thinking is, well, if it helped them, it might be preventative for me. It's not going to hurt anything. So I'm going to throw a weighted vest on when I'm walking around my house, and doing housework or walking on my treadmill.
Mhm.
And hopefully that'll, give me a little bit of an
Mhm.
edge. Can you talk about some of those kind of basic lifestyle?
Absolutely. And this is again where medicine, we're so good at treating osteoporosis. We have 10 pharmacologic agents. We have so many options for treating women who've had a fracture or who have really low T scores. And we'll talk about hormone therapy here in a minute. But our prevention, we do have, good information. Some of it is a little bit mixed on calcium, but most of the meta-analyses have shown that getting adequate calcium, that varies for each person, whether you're absorbing the calcium correctly, whether you're taking the right amount of, calcium. So at least 1,000 or 1,200 milligrams of calcium in diet and or supplements.
Mhm.
There's always a research that says, well, too much calcium, of course, causes kidney stones, or there was this whole question about cardiovascular calcification that's really been debunked even by the
Okay.
cardiologists.
I've
So,
heard that, but I need to read the study on the
right,
debunking.
right.
So,
So again, calcium is important. And sometimes at menopause, this is the cruel trick that's happened, is that we are losing more bone density or bone resorbing. So we're actually leaching more calcium out of our bones. So it's
mhm.
the time we need more calcium because there's some changes again that happen in our parathyroid hormone and things of that nature. So it's not just all, and that's the end of the story, right? We do know that there's muscle, bone loss, there's other hormonal changes that are happening. So calcium is really important.
So there's a difference between, and I want everybody to understand, calcium, dietary calcium is calcium from food, right? Calcium in the nutrition that you eat. And then it's a little bit different than a calcium supplement. Can you talk about the two differences and what the data
Yeah,
shows?
Absolutely. So again, this is like, taking women with osteopenia, osteoporosis, and honestly going through the menopause, even, the Institutes of Health, and they've all recommended sort of a relative like RDA, or relative daily allowance, that most people should hit. It's hard to hit a lot of that. But again, it's around 1,000 milligrams for calcium for pre and postmenopausal women. And so exactly, there's elemental calcium, which we can eat in dairy and non-dairy sources, and then there's supplemental calcium. Because again, calcium is like an element. Remember in our periodic table, I have younger teenage kids, and we're like studying the periodic table. I'm like, oh, there's calcium. But we don't just take that as, it has to be connected to something. So things like, calcium citrate, calcium malate, calcium phosphate, there's hydroxycalcium appetite. So these are all, and there's some variability between them. Calcium in food is probably a better source. I mean, I think many of us try and think food first for many different things.
For all nutrition. Yeah.
Non-dairy sources, dairy sources. There's probiotic in calcium. There's protein in a lot of these calcium foods. There's a calcium chew now that is food-based calcium, which is an awesome choice for a lot of my patients who have trouble swallowing tablets or can't get in that calcium. It doesn't cause as much constipation. So there's a lot of options, and it just takes a little bit of creativity. There's a calcium calculator that you can do. And I think a lot of times we overestimate what we're doing, but then underestimate maybe the macronutrients that we're thinking about, like calcium, like protein, like vitamin D, which we can chat about too.
I think there's a lot of misunderstanding around serum calcium levels, and like, oh, my calcium level in my last blood draw, if they get a Kim 10 or something, was normal, I'm fine. Do you want to comment on that?
So good. Thank you. Yeah. I know it's so many of the questions we see in clinical practice, and to us, it's like, oh, of course we know that, but it's great. So serum calcium, when you get your blood tested, that's the calcium, your kidney function. It assesses essentially just how much calcium is being processed through your kidneys. Sometimes that can alert us to like a metabolic bone condition like hyperparathyroidism. You're perhaps taking too many calcium supplements or other conditions. And so it is important, not to say all osteoporosis is due to being a woman or being postmenopausal or your family history. We always want to rule out what we call secondary causes. And that's where we put sleuthing hats and make sure that there's no other underlying condition we can check for. But you're right, the calcium in the blood test is just a sort of a snapshot of in our blood. It doesn't necessarily tell us what our bones are absorbing. Sometimes we do a 24-hour urine calcium, particularly when women have osteoporosis and we can't figure out why, or we want to do that secondary workup. And that can tell us if there's absorption issues, if there's too much, too little. I always call it like kind of the Goldilocks phenomenon for that one. But yeah, I think that's a great.
So let's talk about the impact of a fracture. So the whole reason we're doing this is try to keep our bones stronger. So when and if we fall, and we usually fall at some point of our lives, that we don't fracture. And some people don't even fall; they just fracture, right, from a stand. And I want to talk about, because my mother had a hip fracture, right? But also my mother-in-law has multiple spinal fractures. Now she has metastatic disease, but she had osteoporosis as well. So it's kind of hard to tell which is which for her. And the pain and suffering that women are going through, I think we're not, it's hard to put a number on that and what the impact of that is to someone's quality of life.
Yeah. And I thank you for underscoring that. I think, we, in gynecology and in women's health, we're both in the same sphere, right? We're positive. We want to think about prevention. That's right. Versus like maybe we who are, in their 80s and 90s, and the sequelae that we have from osteoporosis related fractures. And it's hard to sometimes express that to maybe someone who's recently diagnosed with osteoporosis and feels fine and well. And so I think, again, this is where you mentioned a fall. You're absolutely right. The statistics are kind of sobering, and they're not really changing. Is that like 1 in 3 women over the age of 65 will fracture or will fall, excuse me. And generally a sideways fall, 95% of that sideways fall will cause a hip fracture. That's what causes most of the emergency room visits in, women and men over the age of 65. So falls and fractures. So again, there is a lot, of downstream effect. Again, to get a little bit more sobering, hip fractures are associated with a 20 to 30% mortality within a year, especially if you have a lot of underlying conditions. And maybe that's not women in their 50s and 60s, but it's women, 70s and 80s that have lived a long life and haven't had any cardiovascular risk or breast cancer. And we see on par more women having hip fractures, then they might have uterine cancer or ovarian cancer and things like that that are sort of feared, and we kind of think are more gynecologic issues, but actually it's the fractures and the urinary tract infections that are ending women again in long-term care, or loss of mobility. 20% of women now walk or live independently again after a history of a hip fracture. Other fractures
Yeah,
you mentioned.
my mom will never
Yeah,
walk again. She hasn't gotten out of the wheelchair
yeah,
since
yeah.
her
So,
fracture, so I get it.
and how old is she?
88.
Yeah. So, and that's what I mean. Those are like the fractures we can prevent. And that's why I say, like, you're not thinking about your hip fracture at 50 or 60, but if you have osteoporosis and you're going to see your numbers drop, 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 and we're going to age, this is where we do start to see the fractures. And it's not so, again, it's not a fear-based, it's a prevention-based discussion.
Okay.
Vertebral are significantly painful. I mean, it's the patients in my practice where I wish, I wish I knew more pain management folks, and I want to send them there right away. And we do, because it can be very painful, especially multiple vertebral fractures, right? We lose height. It can compress our vertebrae. So it affects our diaphragm, affects our breathing, affects how often people are getting sick or constipation, not to mention pain. And then I have patients who say, I just never can move again the same. I can't, every time I pain. And so those can be from a bend, a twist, a turn. And again, generally when women have a T-score of minus 2.5 or minus 3, so really sort of more fragile bones, that we see those. And again, these can all be prevented, right?
Right.
And times we don't know that we have a low spine bone density until we, again, do a DEXA or have a fracture. And it's why we talked in the beginning about it's so important to know your numbers, find someone that can actually talk to you about these numbers and what they mean.
So in your osteoporosis prevention starter kit,
Mhm.
what would you recommend, like just in general?
Yeah. And I love your book. I recommend, I love the word toolkit, because I'm like, I see a lot of patients in my practice and they're like, oh, I was feeling so bad, but now I'm feeling great. And, we've started things, we've done targeted supplements, and we're doing recommended certain things like exercise or hormones or whatever medicine. And I always say, well, it's not just one thing, right? It's the toolkit. And it's
Toolkit.
I love it. It's such a great word. It's the exact same thing when we think about when we think about prevention. And again, I always like to use examples because that brings it to life, right? So when I think prevention, I think, well, maybe someone who is entering menopause, let's say 52. Let's give an example of someone I saw this week. 52, she has a T-score in her spine, minus 2.0.
Mhm.
She never knew she had osteoporosis. She is strong. She's been athletic, worked out her whole life. Her mom had osteoporosis. She had menopause at 48. So that was now, 4 years ago. So no one did a DEXA then. She's been suffering with hot flashes since then, now has vaginal dryness and sort of the cascade of effect of not sleeping well and unable to exercise, brain fog, all the things. Not everyone's like this, but again, a lot of perimenopause and menopause women we see with certain symptoms that are, are hallmarks. And again, we do her DEXA. She has osteopenia. So for sure, for her, we want to talk about getting back on getting the appropriate amount of calcium, whether it's in your diet or supplementation. Vitamin D, check her vitamin D level. So 25 hydroxy vitamin D. Most of the specialists agree that having a vitamin D level, 25 hydroxy vitamin D between 40 and 60 is recommended. Deficient is less than 30. 20 is not sufficient. Over 80, there might be some toxic levels. And so we store it in our fat and fat tissues, and we don't know if that's good or bad. It can contribute to high calcium levels. So, again, it's the Goldilocks phenomenon for the vitamin D. There's lots of ways to get vitamin D. Vitamin D3 is usually preferred daily, generally better a couple times a week. So we're talking about calcium, we're talking about vitamin D. I'm talking about alcohol, right? So we know alcohol, very important, increases bone resorption. So again, if you ask the breast oncologist, they say no safe level of alcohol. If you, again, alcohol, we want to keep that, you could say zero, low, I would say, again, 3 to 5 drinks a week maximum.
Limit. Okay.
Limit. And then also, again, are we smoking? What can we do about these lifestyle factors? I know it's not an easy, let's just stop smoking with a, whatever. If that's an issue, we talk about the strategies that could do that. This one was not smoking. Protein, we know that the protein supports our muscles, and our bones and our muscles talk, right? And so we know that, and again, we know this for all the other menopause symptoms that are just going to help lots of other things. So trying to get, depending on how active we are, 1 gram per kilogram of our body weight in protein, and divided doses. Again, lots of ways you can do that. There is some evidence with protein there. For this woman, we're talking about getting back on resistance training, or maybe she was doing some resistance training. We can talk, we'll table that for maybe a second, but doing some sort of resistance training, posture and balance. Everyone who comes into my office, we do a sit to stand test, we do balance testing, we talk about their proprioception, their hearing, anything that could affect their vestibular issues at all ages. And then for this woman, she was, we talked about risk benefit of hormone therapy. She was already having hot flashes, vaginal dryness. She had osteoporosis. It was a no-brainer. She didn't have any contraindications for hormone therapy. We talked about the different doses and we'll start her on hormone therapy. If she had none of those symptoms and she still had osteopenia, I would still talk to her about hormone therapy.
Okay,
Why?
and I believe it's FDA approved for the prevention of osteoporosis.
And somehow that gets like pushed down to the third, final option every time. But most doctors and most clinicians, unless you're trained in gynecology or menopause, don't know that. Like, it's not their own fault, unless they're educated endocrinologists or internists or gynecologists. And so, or they don't feel comfortable prescribing, right? They need to find someone who could prescribe. And so those
Could do it.
is possible.
What kind of percentages are we talking about with, just starting HRT, assuming she's doing all the lifestyle stuff? What is the benefit of HRT for prevention?
Yes. So again, we have, everyone probably listening and in your book have, talked so much about the Women's Health Initiative study. So we have that study. We have the Danish Osteoporosis Prevention Study, the Million Women Study, a couple other meta-analysis that really show that when we start bone hormone therapy, and particularly women with osteopenia or osteoporosis who are at low absolute risk for fracture, the bone mineral density improvement we can see is anywhere from 5 to 7% in the spine, 3 to 4% in the hip, which is, again, important when we look at the bone mineral density changes on a DEXA scan, when we actually can compare. And of course, they did this over time, and those women were on this for a long time. We know that hormone therapy improves bone density dramatically in the first 1 to 2 years because it fills in the little osteo, it prevents those osteoclasts, which we're kind of working in overdrive through the menopause transition. It helps them sort of tamp them down. And so there's a more balance between bone formation by the osteoblast and bone resorption by the osteoclast. And how we know this is working, and I think this is our biggest Achilles heel in the menopause world, right? We have very few targets, like in our blood and like testing and all our other testing. There's something you could test for called the Serum CTI, that a marker of bone resorption. Sometimes that's estrogen's low and we replete the estrogen and those levels change and it's like everyone's happy. And sometimes we have to just wait and do a DEXA scan, make sure we're talking about standard dose estrogen for the woman we're seeing in front of us, whether it's what her risks are, what her goals of therapy are, and we recheck on a DEXA scan to see if the bone mineral density is improved.
So
I think
so standard dose, which a lot of people don't get and a lot of gynecologists may not understand, is 0.625 of Premarin or 1 milligram of oral estrogen, or the equivalent of the transdermal, the 0.05.
right, 50 microgram patch. Sometimes, again, in the gel, again, has to be sometimes dosed up a little bit higher. We know that there's 20% of women from the Menopause Society, paper that said that don't absorb. I often find women like that are already having symptoms and we can find that out. But this is difficult. We know that, women who are earlier in the menopause transition, like the woman I just said, we probably do need closer to standard doses of hormone therapy to prevent that bone loss.
Mm-hmm.
When we're further from the menopause transition, this is data from the PEPI trial, who women who are maybe 55 to 64 and a little bit further from the menopause transition didn't need as much estrogen to offset that bone loss. And that's why little amounts of estrogen sometimes can go a longer way in the bones when we start to go past 60, 70. And we have some small studies that guide us on that. So again, when I have someone who says, well, I'm not within the 10 years of menopause and window, and am I safe, or can I use hormones? It's very variable, right? It's individualized and variable.
Right.
We need to look at the care, look at your cardiovascular risk, your breast cancer risk, but remembering that women in the Women's Health Initiative were 50 to 79, and they all used estrogen, and they all had a reduction in their risk of hip fracture, vertebral fracture, and non-vertebral fracture, right? So it's not just the 50-year-olds that have benefited. Some of the older women who had osteoporosis all benefited. It was the same across all the cohorts. So it's very important to understand that it's different versus maybe thinking about our cardiovascular risk or our time. it's quite different. That being said, if someone has severe osteoporosis and they've had an osteoporosis related fracture, or they have very low bone density and it's been irresponsive to like a bisphosphonate, or they're transitioning off of a medication like Prolia, hormone therapy is not the option for them, right? We need to be thinking about matching the risk with the treatment that we
So
recommend,
let's
right? That's fair.
briefly talk about the treatments. There's a lot of chatter in my world about side effects and fear and can you kind of briefly touch on, in my day, it was Fosamax. That was the first med. I was in residency when it came out. We were so excited to have something. We were also, most of my residency, prescribing HRT pretty regularly until my last year, which was 2002.
Mm.
So
My,
when
yeah.
the bomb dropped from the WHI and we stopped prescribing, so all of a sudden these the bone building or anti-resorptives, which came later.
Right.
Can you talk about the classes and
Sure.
Medicaid? So she has osteoporosis. Maybe she's not a candidate for HRT. If you're going the endocrinology, straight up endocrinology, and they're terrified of hormones,
Mm-hmm.
of estrogen, or haven't been educated, what are her options typically going
Yeah.
to be?
So I always like to start to say, you asked me about prevention, and I think we have a couple classes that are really indicated for prevention. So we talked about hormone therapy, which is one class. Another class is one that sometimes gets forgotten, which is the selective estrogen receptor modulators. It's called Duovy, or conjugated estrogen with beta-doxivine is one. Raloxifene is another. Sometimes those can be helpful for women who might just have a low T-score fine, or have a family history of breast cancer or dense breast themselves, where we're concerned slightly lower the risk. So that's a really great prevention option. And then you mentioned bisphosphonates. I'm the same. When I started at my gynecology practice after my fellowship, they were like, we're prescribing hormones and oral bisphosphonates. And that's what everyone was prescribing. And a lot of, discussion about, everyone coming off of hormone therapy, and then everyone transitioned onto like Fosamax, right? Because the timing was sort of right for that. So those large classes, the bisphosphonates, which is a very large class, which again also just prevents, called the anti-remodeling or anti-resorption class. It prevents the osteoclast, disables the bone breakdown cells, and so it allows, again, your bones to kind of form from preventing bone loss or preventing that sliding down effect. There's varying different types for how long they work, how strong they are, the affinity they have for the osteoclast. So things like alendronate, residronate, abandronate. There's an IV formulation called zoledronic acid or zoledronate that's been studied actually now closer in women between 50 and 60 that can be effective as a prevention strategy. So all these are prevention. At the higher doses or more stronger intervals, they also are used for of osteoporosis, so can be used in women who might be at low to moderate risk for a fracture, don't have acid reflux or esophageal issues, or severe kidney dysfunction, or we saw a glomerular filtration rate or GFR less than 35. So they're okay for like the women who maybe can't use hormones or a Serum, and might want to prefer this option for a short period of time. Generally, we prescribe those for 3 to 5 years because they are ineffective at reducing the risk of fracture, and the effect plateaus.
Okay.
On density, unlike hormone therapy, we don't see that.
So let's quickly review, because I think I skipped over this question. Bone metabolism. The bones you have are not the bones you had 5 years ago, right? So in normal healthy bone, we are constantly chewing up old bone and laying down new bone. That's why when we break a bone, it heals on its own as long as we line up the bone with a cast, right?
Right.
And so with aging and then menopause, what happens to that normal process?
Yeah. So we've kind of like danced around it, and I know the bone. It's very fascinating, right? So there's not many things that grow a lot. And I always say that 10% of our skeleton remodels yearly after the menopause. But again, we're growing and building new bone or long bones. It's why we have such a growth spurt at the time of puberty, and then our epiphyses fuse and we stop growing. And then we're again constantly after that growing until again that peak bone mass, which is in our 20s and 30s. So shocking for a lot of women. I see at 55 for in their 50s who have 20 and 30-year-old daughters. They're like, oh my God, is it too late for her? And I'm like, no, this is what we focus on. But again, this is the education that we're passing down, right? Which is awesome, I think. So again, we're remodeling our bone, and that balance that you nicely said, is sort of totally thrown off at menopause, or if there's an underlying metabolic bone condition like a Paget's disease or a hyperparathyroidism, where you're just breaking down more bone than you're forming. Your bones can't keep up with it. Unfortunately, as we age, we from hormones and different proteins and immune function, we just don't build up as much bone. And we know that now, like the astronauts going into space have made like bone look cool, right? Because we know that also when we do less walking, running, aerobic exercise, resistance training, we also don't stimulate our osteoblasts or our bone forming cells. So that's a little aside there. So all the classes of medicines we talk about, I always say, are kind of like just tricking our body. We're either preventing our bones from breaking down, stimulating the osteoclast, preventing the osteoclast from working, or we stimulate the osteoblast or the bone forming cells and the osteocytes, which are the nerve conductors of the cell that help us also mineralize and strengthen our bones. So the classes of medicines I talked about were the anti-resorptives, again, hormones, bisphosphonates. There's one in there called denosumab or Prolia, which is a
Mm-hmm.
subcutaneous every 6 months.
Lots of questions about Prolead. Yeah.
We can hit on those at the end, but and then the other class is the bone forming. We have three medications that form new bone. One is called the baloperitide or Timlos. I see some people saying they're on that one. Teriparatide or Forteo, which has been around since 2002, and then one called the Evenity or romosozumab, which actually is like a sort of a dual agent. Prevents bone from breaking down slightly and stimulates new bone formation. And naturally, these medicines are reserved more for women who might be at the highest risk or still who might be treatment naive and had a fracture or a very low T score. And that can still be women who are in their 50s and 60s. It doesn't have to be the Hail Mary medication at the end of when we've had a fracture and now we're finally giving you a medicine that might be the most effective. The paradigm really in the bone health world, thank goodness, is to like move that forward, like treat the women who are at the highest risk, women who've had a fracture, women who have a very low T score, women have multiple risk factors or failed other things. We want to move those medicines earlier. And so we're doing a lot of education on that, a lot of advocacy on that.
Okay. What's the biggest myths or misconception that you hear about osteoporosis?
Yeah, so I think one is, particularly if women who have had a fracture and they say, well, anyone would have broken a bone if they fell like I did. I hear it all the time. We have a lot of like, undercutting or saying sort of like, this isn't that important, like pushing it sort of down in the importance. I had a fracture, I broke my wrist, I fell on the horrible sidewalks of Chicago, and then I healed and I'm fine now. And then we get a DEXA scan and it shows maybe they have low bone mass, which we could, or maybe they just have they have crossed right into the osteoporosis category, but there's a lot of, doubt about treatment or do we really have this condition? And I think again, we have a lot of tools to help us diagnose, bone conditions now in osteoporosis, like the DEXA. We have something called the trabecular bone score, which helps us determine the bone quality. We have the fracture risk assessment, which is a free online, tool that you can use. And so I think a lot of times again, it's just because osteoporosis isn't a condition that's out there. We don't have any celebrities, although we have had some celebrities fall and break some bones in the past years, say I have osteoporosis and this is what you need to do. So I think that there's a lot of either it's shame or it's an old woman's disease. I can tell you if you line up my patients, women in my practice, I have so many women in their 40s and 50s and early 60s with osteoporosis, and they're looking to be proactive.
Same. They end up in my office to be proactive
Right.
about it.
Or I have women in their 70s and 80s and they've had a pelvis fracture and a vertebral fracture. So I think again, it's like knowing your numbers, being proactive. I see treatment as preventative. It doesn't always have to be a pharmacologic treatment. And no understanding what the risk and benefits of those are, breaking down some of the misconceptions, like you said, and barriers.
What's the one thing you want every woman listening today to take away from this conversation? We still have 1,000 people live.
Yeah.
Wow, listen.
Incredible. I mean, I love it. I mean, there are so many things. I mean, I think in women's health, we are, again, like at this amazing space, I used to, be on the airplane reading my menopause journal back at like the journal, the copy. And my son, who's almost 12, I took him to the meeting when he was like 3 months old in his little scrubs and I was like holding my menopause like journal so no one could see it. And now I think it's amazing that we are owning, the midlife and beyond. I always say it's not just like, because I think some people feel like, oh, I'm done with menopause, so it's not important for me. And I'm like, no, no.
We're never
Like,
done.
right, like I never went through menopause. I'm like, yes, you have. But that we have a lot of time during what's important during and then after, and that we have a lot of these options. I'm huge into options. Like we have options for stress incontinence, we have options for hot flashes, we have options for vaginal dryness, and we have so many options for osteoporosis. So don't be told you have one option and that's it.
Any role of testosterone in osteoporosis, prevention, treatment,
Yeah.
whatsoever?
So this has become like, kind of a hot topic. And, like many things in osteoporosis and women's health, we need more research. We have a couple small studies that look at, again, when we check like serum estrogen or blood estrogen, and we compare that to women who are in the lowest quartile of testosterone versus women who have the higher quartiles of
Naturally, yeah.
testosterone, that women with the higher quartiles of testosterone seem higher bone mineral density. But could that be due to muscle? Could that be due to the fact that testosterone gets converted to estrogen? So sometimes when we take that out, we don't see a strong correlation. Now, will we find that out in the future? We know that men have larger bones and never have a menopause, so they tend to have higher bone mineral densities from the start and bigger and stronger, more muscle mass. I think this is a huge area for opportunity for research. I don't necessarily, again, I follow a lot of the guidelines. I don't necessarily start testosterone for women with low bone density.
Mm-hmm.
We talk about libido, which is a very common concern in 40 to 50% of women. And sometimes we're hitting two stones. And I sort of know that research. I think we need a little bit more, but I think, we learned about estrogen. Now we need to learn more about, testosterone and other hormones.
Agree. Lots more research for us. Yeah. Where can people find you? So everyone right now, we're up to 1,100, absolutely has to follow you. Your Instagram is your business. So
Oh,
Bone and Body Women's Health, Bone and Body WH.
I,
So follow her right now. She is all things education. I love following your page. I've learned so much from you. Let's grab a couple questions. I
yeah,
mean, they're flying fast and furious.
yeah.
Tell you what, let's see. I wrote down a couple.
Okay.
How much estrogen is needed? We talked about that.
Mhm.
And then like everybody's asking, when should I go get scanned? Should I pay out of pocket for a bone scan?
Yeah.
What is the bone scan?
Yeah, so like I said, this new indication, you should be able to advocate for yourself, ask your primary care doctor, gynecologist, sports medicine. We should be able to get these. Women shouldn't have to, we're now self-scheduling mammograms. I mean, why can't we self-schedule a DEXA? Maybe that will come. Actually, some centers around the country do allow that, right, to help with access. And not pushing, people away from, oh, I can't get that, or oh, it's a very low radiation test, very simple. You want to do it correctly, though. You want to get it done at a place that is, ideally ISCD certified, which is, the International Society of Clinical Densitometry. So the scanner knows what they're doing, how to position you, how to read it correctly, because good information in equals good information out, right? So that's important. And there are some freestanding clinics that are doing this. I think, again, sometimes they don't fraction where the DEXA needs to be done. They give you a total bone density score. They don't look at spine, the
The
hip
hip
separately.
and spine. Yeah.
But if you get that done somewhere else, then I would bring it into someone who might know, or ask your general doctor if you're seeing someone, or a gynecologist, where can I go get this read, or what do you think about this, or should I be referred to someone to understand this a little bit, better. So, or you can yourself again be advocate and go on the websites, the menopause.org, the Bone Health and Osteoporosis Foundation.org. Those are all places that you can find, people who know about menopause, know about osteoporosis, things like that.
Okay. Thank you so much for this. Our followers have
Yep.
really loved this. There are still over 1,000 who are just probably taking notes like crazy. Guys, I will save this. It will be available. It will be uploaded as well to YouTube so you can watch it, take all the notes. And if they want to come and see you, where can they find
Yeah.
you?
So I am here in the Chicagoland area in beautiful Winnetka, right on the water here in Lake Michigan. I do some educational consults. So women who would send me their DEXAs and talk about osteoporosis. Sometimes it's more the complicated cases, or if you're in like a desert of, areas where people don't know a lot about osteoporosis, or you've asked those people and you're looking for a second opinion. And I just appreciate this time. I think, again, the more we educate ourselves, the better we are as women and as a community.
All right. Well, have a great night. All right, everybody. Bye.
Thanks.
Take care.